simultaneously. And I said, I better check tomorrow's schedule.
Yeah, I had sent out I said like the email had said potential case, and then I had confirmed it, but I hadn't actually changed the invite on the thing. So I did send it. I did edit the invite so people got an alert this morning that it was happening, but
I haven't gotten to that email yet.
Well, thank you for waking up and being able to help.
Oh, I've barely been to sleep. We had in the last 7 days now, we've had 7 patients in 10 sessions.
Oh my goodness. I'm glad I'm a pathologist.
So
yeah, I mean, I do my best. I mean, like I think you're the doctor that one time I was sending out reports on a weekend and you sent me an email being like, why are you doing this on a weekend?
Yes.
And you're like, make sure you protect your time. But see, I did make the wise decision. I will work on a weekend, but that overnights would have killed me. I'm not a person who can withstand overnight.
I don't bounce back
positions.
nearly well.
Okay, we're getting people logged in.
Okay, and can I share? I've made a few slides to present the case, but I didn't have time to find cute pictures.
That's
I was
okay.
going to try to see if I could log on to our PACS to come up with the ultrasound, but that was not easily done.
It looks like a lot of people are joined. I think Mary or Jessica, if Jessica Hokamp is going to get on soon, if we can help watch and monitor when people are in the lobby.
Okay.
Yep. I'm kind of able to admit the others, but just in case I get distracted. Oh. Thank you. Thank you, Dr. McGinn. Okay, as this is getting started, it is recording, and again, the recorded sessions need to get maybe a separate home or some kind of different home that maybe we can have. Summer might be able to help us because they are kind of educational content.
Yeah, Summer and I talked about that yesterday, actually. So we are in the process of porting everything over and merging it with the ACVNU's YouTube channel. So
that would be great. Yeah,
yep.
Awesome. Okay, so eventually, once that is confirmed and they are in their correct places, then for those of you guys that are pathologists and don't necessarily know what we're talking about when we say the ACVNU, we have the American College of Nephrology and Urology, or nephrourology, I'm not sure which, but we are training future nephrologists and urologists through this college. And it has a curriculum. It uses a couple of learning tools so that we can have meetings and classes and share assignments and share journal club and everything like that. So it is kind of a home base for a lot of discussions. Like a lot of us just got off of journal club with Dr. Chen maybe a few minutes ago. So there are a lot of more educational resources for those of you guys who are pathologists but want to know more about kidney. And so once we get these sessions that have been recorded switched over to their future home, we will send a big alert, I guess, so that everybody knows the new location. And I do know Mary Nabity and I were fortunate enough to be in Australia last month. And we met a lot of Australians that were very excited about pathology, about the kidney, and we met a lot of the clinicians as well. It's obviously very almost impossible for them to make this session because it's not time-wise easy for them to come to these sessions at this particular time slot. But they would be excited about being able to watch the rounds. Right now I'm recording from my living room because I felt like today was a rainy day and I wanted to cuddle with my dogs while I talk to you. Sometimes I record from my office, but today is just a rainy day outside. Also,
Right,
as
so
I just want to do one
I
more
just
quick.
think-
Go ahead.
Go ahead.
I was going to say one more quick housekeeping is that sometimes people get knocked off the list. I say this every month. So if you've realized you haven't gotten an invite in a bit, please send us an email and we will make sure you're added back to the distribution list. That's all I have.
All right. So Teams is not letting me find, I just tried to join Teams and share, but it won't. In my list of what I can share, I have a whole bunch of PowerPoints and none of them are the few that I made up.
Is it on your desktop?
It's on my desktop and it won't.
So you can
I went to my desktop with the PowerPoint and it said join Teams with that, and I did.
Could you share, because you can either share a screen, like my Teams is sharing a screen or sharing a window.
Yeah.
But you did.
Yep. What do you,
And
tell me what you want to do, window?
Yeah.
Oh, there it is. I just found it. I just found it.
It does get a little confusing, so.
Yes, okay. I just found it. All right. Here we go. Been a long time. So the case I'm going to present today is Finnegan. He's a 1.2, maybe now 1.5-year-old intact male Boston Terrier who weighs 6.46 kilograms. He was actually referred to us for a kidney biopsy to further define a persistent azotemia and proteinuria, which had first been identified in June of 2024 when he went to his local veterinarian for neutering. The owner reports that he has normal activity. She doesn't feel that he's polyuric or polydipsic. He occasionally has some marking behavior in the house. And the only other thing, although she feels he's certainly healthy, perhaps maybe a slight inappetence, but she thinks as she stated it, he's always been a picky eater. So physical exam is pretty unremarkable. His diet has consisted of.
You're in like that presentation mode. It's not actually like advancing the slides.
It isn't?
No.
Oh, okay.
We can see your, like, you know how you can see the slides on the thumbnails and then your actual one. It's not actually advancing the slides.
Oh, okay. Wait a second. I'm not.
Okay, there it goes. That's good. That's perfect.
Oh, now you're seeing I'm seeing my unpresentation slide. I'm not in slideshow anymore.
Yeah, we can at least see what you're talking about as far as it's big enough for us to read.
Okay. So slideshow wasn't working? All right.
It was just showing, this exact kind of thing, and it wasn't advancing as you were talking.
Okay, let me try one more thing here. Does this advance now? Or is it still failing miserably?
It's still the same slide that says Finnegan with a physical exam.
Okay, so let me go back that way then. All right. So okay, so this is where we're at. Farmer's dog is his diet, with the owner putting a variety of cooked meats on top. He had typical past pertinent history of a puppy having Giardia rounds and hooks. The diet had been changed to KD just a few days before his visit to us. The referring veterinarian's diagnostics, their pre-op blood work, this was, remember, back in June, his BUN was like 100, his creatinine 1.9 at that time. He had, on a urinalysis, hematuria 2+, 4+ proteinuria, a urine specific gravity of 1039, and a negative culture. And then all we had within the record was the advice of let's recheck those values in 1 month. The owner came back to that practice, and with the report, the dog was still acting fine at home, at which point they repeated blood work, and the dog had an albumin of 2.2, a BUN of essentially the same, 102, with a creatinine of 1.7. SDMA was 18. UPC was 7.8. Tick panel was negative. Lepto mat test was negative. They ran a resting cortisol with a 2.2 baseline. Their ultrasound showed no structural abnormalities. The ultrasonographer commented, well, possibly there was a slight increase in echogenicity. Then now it's 1 month beyond that. So 2 months into the first recognition of his azotemia and proteinuria, he is still doing well at home. The owner feels no clinical signs, except maybe once again this slight inappetence, but no change in activity. His weight is maintained. Body condition score at our practice was normal at 5 out of 9 with a normal muscle conditioning score, no more murmurs. Both testicles were descended. Otherwise, he had an unremarkable PE. He was a hyper little Boston with a BP of 160 systolic using the Doppler. His complete blood count was within normal limits. He had adequate platelets at over 363,000. His PT was normal. His PTT was just slightly prolonged. On chemistry, for our lab, his albumin was normal at 3.5, BUN a little lower at 87 with a creatinine of 2. His cholesterol was a little elevated at 524. It was a fasted sample, and calcium was in our normal range. And it was a fasted sample. We had hoped, oops, why I just did that. Let me delete that. And this is, where am I? Here we go. Our urinalysis, the specific gravity was 1027, trace sperm, had some granular casts, occasional red and white cells, 2+ heme, 3+ protein. His urine pH was 5, UPC was 7.8, culture was negative. On our ultrasound, he was assessed as having a normal abdomen with normal appearing kidneys. At that day, he had come in fasted. We were unable to with the plan of actually biopsying him. We were unable to, though, because his little spleen and intestines, no matter what position we had him in, did not give us a window that the ultrasonographers tried as they may, felt comfortable biopsying him. So in the meantime, we continued him on his kidney diet. We got urine that day to send in to Texas for an SDS page. Started him on a really low dose of telmisartan at 0.1 mg per kg once a day. And the plan was to get him back in a week or two, recheck his BP and kidney values, and retry his ultrasound. So he came back a couple of weeks later, activities still unchanged, happy, healthy, apparently healthy pup in terms of how his energy level was. He was super excited that day with a systolic blood pressure of 180 with a same size cuff, a number 3 cuff on a Doppler. His BUN and creatinine pretty much unchanged. BUN of 106 and a creatinine of 1.9. His ultrasound, normal, same thing, normal appearance, normal corticomedullary distinction. His left kidney was 5.13 centimeters, his right 5.18. Sorry, I wasn't able to upload to my PowerPoint from our PACS system from home while I was working on this lecture. We biopsied him with a 18 gauge barred biopsy needle. We obtained 3 cores from the left kidney. Everything went well, and he went home the same day. We got a recheck of him a month later. He came in and saw the service. His he was still on Hill's KD diet. His energy was normal, but his appetite was a little worse. In the interim, he had been on clopidogrel that was started actually right after the biopsy, and the telmisartan, but his telmisartan dose had been increased, and he was currently on a mg per kg. His average blood pressure on that day was really fairly high. His kidney profile, his albumin was 2.9 with a BUN that had jumped to 176, a creatinine of 2.1, a phosphorus of 6, and everything else was normal. His SDMA had increased a little to 21. And further follow-up, the owners did get back and know just a few weeks ago, or last week, I guess, that I found this in his record, that they had called to say that his energy was okay, his appetite was worse. They had elected to stop all of his oral meds, and he was feeling better, and they were just going to enjoy him for as long as they could. And that's where we stand. He had been seen by, I had been off clinics for a bit, and so I did not find in the record in client communications if at that last visit, if they had taken a call to lower the telmisartan dose and add in amlodipine or what. So a lot of the follow-up was being done at his local veterinarians as well. So that's what I've got for presentation. Now it's time for you guys to take it over.
Yes, thank you. Everybody also, please applaud Dr. Lobato. She was up and doing dialysis for 3 patients yesterday up until the middle of the night, right? You might not have been able to sleep.
I had 2 hours, 2.5 hours.
Oh, goodness. I admire your life.
We have another one on the table. So I think I heard some of Hilla's journal club, but I was distracted.
I can understand. Well, I'm very impressed that you were even able to speak coherently after a lack of sleep. So, Dr. Hokamp, would you mind presenting, because you did get the SDS page before we got the biopsy. So as everybody remembers from the history, the original attempt at a biopsy wasn't successful. And so they had taken urine and they had submitted it to Dr. Hokamp and Texas A&M for an SDS page. And I don't know if you can quickly show that.
Yeah, I am. Is that showing?
Yes, perfect.
And I have the right case.
This is the correct case.
Okay. All right. Let's see. I'm trying to see if there's anything interesting. Definitely some casts in the urine. Okay, so this one is urine sample here in the blue box. I called this moderate to severe glomerular damage. We have an expanded albumin region, and then these high molecular weight proteins between 100 to 200 kilodaltons, multiples of them that are variably prominent, which is why I went, pushing towards the severe side there, but no bands above 200 kilodaltons. I did comment that I suspected some degree of tubular damage. However, given that the dog was intact and we did identify sperm, we do know that prostatic proteins will also fall in this range. And so that always creates a little bit of a confounding issue for interpreting tubular banding patterns. But I wasn't able to give anything very specific here in terms of me really suspecting ICGN or anything like that. So that was about as far as I was able to go at that point.
Okay, thank you. Again, I guess a couple of quick take-home points from the SDS page is that it can be very supportive of an indicated need to consider biopsy. So a lot of times we will get samples that they aren't sure if the owners are on the fence of biopsying, and so they submit the SDS page, and then Dr. Hokamp can give them sometimes really good evidence that they should go ahead and proceed with the biopsy based on the banding pattern. Then we will receive the biopsy maybe a couple of days later, a couple of weeks later. And then we also, that there's like the kind of included price for biopsy and SDS page together. So if we get the SDS page first, then we get the biopsy, we still give you that same kind of bundled price if they come within a sequence of each other. So we try to at least account for that. So it's not like you're paying for twice, although you're paying for 2 shipments twice. And then also, again, just making sure you have your signalment correct, because obviously if we hadn't known it was an intact male, then it would have been a little bit more confusing for those prostatic proteins. So a couple take-home points for that. The biopsy itself is a little now everybody's probably going to see them in mirrored image, is a little it's a little maybe it presents a sad story, but we kind of already know it's a pretty young dog that has renal disease, and as we've already gotten the follow-up about, they're kind of at least hoping the dog feels comfortable and with its quality of life in the future. You kind of already have an idea that this is it's not a happy end result. So I guess I'm just going to preface it that way. Hopefully everybody is seeing a core tissue. Dr. Hokamp, can you confirm?
Yes.
Okay, so we have really good cores. The spleen and the intestine and everything like that were behaving when they did the ultrasound this particular day. And we have a little bit of skeletal muscle as well, which is fairly normal. Well, the skeletal muscle itself is normal. The cores are mostly cortex, and you can already see at this kind of eagle eye view that you have a lot of increased cellularity and then also increased pink material that are separating the tubules. And it's pretty consistent in each of the biopsy cores. Remind me, he was like 1.75, almost 2 years old, I think, Dr. Lobato, correct?
1.2.
Okay. So for a young dog, this is not typical to have this much kind of interstitial fibrosis, interstitial inflammation. And we can already start to pick out that some of these glomerular structures have scarring as well. And so there's already quite a bit of chronicity to this biopsy. When I look at biopsies, I've always said this before, I prefer looking at the PAS first. It gives me an idea of glomeruli and their cellularity and their glomerular basement membrane thickness. We get our biopsy samples scanned when we basically always get the H&E and PAS scanned at the same time, so I have those two to compare each other. The H&E is my favorite for assessing degree of inflammation and then type of inflammation. So we're going to do that right now while we're at when we're already on the H&E. And so we we do have the opportunity to call on people. So I'm going to call on, oh, Haley Dodson. I've heard that you are a anatomic pathologist at Texas A&M that likes the kidneys. So what type of, if you wouldn't mind unmuting yourself and telling us what type of inflammatory cells you see here. Hopefully you can unmute yourself.
I'm so cracking up that I told her to attend today, and I didn't prepare her that you might call on her.
Sorry, she's gonna dissect some kidneys for us later today. So
yeah, we're gonna attempt. I saw the images. Yeah, it's a little blurry for me, but they look like it's a mixed inflammatory population. I could see some plasma cells, so you can see like the Golgi clearing, some lymphocytes, and probably some histiocytes or macrophages.
I completely agree. And that's usually what we're going to see in typical interstitial nephritis or interstitial inflammation is you'll have some lymphocytes and plasma cells. This one, as I'm pointing to here, is a very good plasma cell with our little halo that we were talking about. There might be a polymorphic nuclear cell in here as well. But having that and some admixed macrophages, all of those are very, very common in inflammation. Usually it's kind of almost just a boilerplate word when you're talking about the inflammatory response. The only time I get really excited that something specific is happening is when I see an eosinophil dominant inflammatory response or a neutrophil dominant inflammatory response. That is above and beyond, and that's something where I think, okay, there's activity going on here. Maybe there's bacteria in here. Maybe this is kind of a hypersensitivity reaction. But I would say 75% of the time we get to see this mix. That is exactly what is displayed in front of you. Okay, so that's kind of the H&E utility is looking at these areas of inflammation, kind of confirming they're all similar to one another, and then going to the PIS, which is the next one. So again, I usually get this the exact same time I get the H&E, and I use this to count my glomeruli. And you can see that there are multiple different kinds of morphologies of glomeruli in this case. We have some that have a mildly dilated Bowman's capsule with a glomerular capillary tuft that is smaller than the Bowman's capsule. We have some that are almost virtually entirely sclerotic. So this thing used to be a glomerulus. We might have like one single a functioning capillary segment right here, but 75% of this glomerulus is scarred. And so we have cells within the mesangial zones and basically a whole broad adhesion of the glomerular tuft to Bowman's capsule. So that's pretty common in this core as well, or in these cores. Here's another globally sclerotic glomerulus. Here's one that is partially sclerotic and has a synechia at the top. And if also, if anybody's having any questions and somebody can monitor the chat, that's also helpful. Here's a glomerulus that's actually partially functioning. So we do have the vascular pole down here. We do have sclerosis at the top. And then we have sclerosis and a adhesion along this base for this one segment. But the middle portion that I'm outlining right about here is at least, I hate when I do that because it doesn't actually, I don't like the way it's, but that little area there is at least being able to be perfused and filter the blood. Okay, let's go back. And then we have one more area down here. Again, segmental sclerosis, maybe about 1/3 of the tuft is actually functional. This one's kind of almost even obliterated. Actually, this is pretty cool. I'm not sure if I saw this as well when I looked at it originally, but Dr. Lynn, since you're a pathologist that looks at kidneys, I'm going to make you speak. What are all these cells out here with these pink, this pink stuff in it? If you're muted, you might be muted. Okay. Dr. Lynn cannot speak. She was texting me earlier, so I was assuming that she was able to speak. But these are podocytes, and those are protein droplets. So we've got a lot of podocyte injury in this particular area. And then there is one glomerulus in here as well. Oh, this guy right here. So this guy here is kind of classic for what we talk about when we say a fetal glomerulus, because you have these prominent podocytes on the surface, and they almost look like little flower petals kind of bulging off the surface of the capillary tuft, and you really don't see a lot of capillary lumens. Oftentimes you will also have a dilated Bowman's capsule. And so out of all of the glomeruli I saw, only one looked like this. So I had one single fetal glomerulus out of, I'm not sure how many, total, let's see, I had a total of 22 glomeruli, and 6 of them were sclerotic, and 1 of them had a fetal morphology. So not definitively diagnostic for maldevelopment, but it did show that there was at least arrest of glomerular maturation for one of these glomeruli. Also, we know this dog is fairly young, is young, and it already has pretty significant loss or scarring of many glomeruli. So 6 out of 22 were globally sclerotic. We'll go to the trichrome. And the trichrome is obviously helpful for fibrosis. When we look at the tubular interstitium, what we want to see is this kind of arrangement here, where every single tubule is back to back towards another tubule. You can have little capillaries in between them, little peritubular capillaries that might be separating one tubule from the next, but you really should have, tubules back to one another. So this area here is fairly healthy, but if we go, 2 fields over, we have areas of dense collagen that are now separating tubules. So here is a tubule that I am trying to outline here, and I don't want to annotate it, but that's fine. And then we have another tubule here all the way this distance that is quite separated by a bunch of collagen. So there's a lot of interstitial fibrosis, especially given that this is a young dog. This down here probably is an atrophic tubule just based on the differential color of the staining. So that's probably tubular basement membrane, whereas this darker blue is probably interstitial collagen. But again, that means that all of these tubules are far away from each other. The trichrome is also very helpful for scarring of the glomerulus. So you see all of this blue matrix here. And you see these adhesions kind of popping out and highlighting the adhesion between the capillary tuft and Bowman's capsule. Oftentimes when you have a synechia, you have abnormal filtration of the blood so that the material that's being filtered, the ultrafiltrate, instead of going into Bowman's space, it actually gets pushed out into this interstitium around Bowman's capsule. So you get this kind of fibrillar, multilaminated appearance around Bowman's capsule. And then a little bit of expansion of the arteriolar walls also is pretty common in this case. So which again goes with the fact that this is chronic and that there is kind of a lot of remodeling of what's going on in the kidney. This is not typical vasculature of a 2-year-old dog or a 1.5-year-old dog. There was that one glomerulus. I was going to try to show the type of, so here, at least you can see this one podocyte out here. He's got this nucleus down here, and he kind of has vacuolated cytoplasm. So these podocytes are not happy, as well as even in the glomeruli that have the ability to be perfused. Any questions so far about the trichrome or the PAS? Camp, are there any questions in the chat?
Not on this subject, no.
Oh, is there another question?
No, it was just like some stuff about how to do sharing, and then I put something in there that you can look at later.
Okay. That sounds
no, I was just saying, like, I can share an image of a gel that would not indicate to me that a biopsy was warranted if you wanted to have a comparison, but that's kind of moot at the moment. Okay,
now it's blocking my. Don't you hate that when like the thing blocks your team, the team little thing blocks your ability to switch to the Jones?
All the time.
Sorry, guys. I'm gonna try to. I'm gonna stop sharing for just a moment. I'm gonna move everything over and then I'm gonna reshare. So one second. I'm just trying to get the Jones up, which is here. Nope, not that. Sorry. Jones. Oh, it's because the Jones hadn't been loaded. That's why. Hello. One second. So the Jones is going to be useful for looking at the GBM and whether or not there's remodeling of the glomerular basement membrane. And so if this, there's a lot of glomerular damage. And so looking at the wall to see if there's evidence of remodeling will help us give it a hint of maybe this glomerular damage is because there's immune complex disease, or there is evidence of spikes or holes in the GBM. And it's a little bit blurry as far as the scan is going to go. I think the better glomeruli are down here. But when you actually get an open glomerulus, like this is one of our few actually pretty well perfused glomeruli, you can look at the GBM and it's fairly smooth and it's quite thin and normal. It's of a normal thickness. I say this every single time I teach about the Jones stain, but the capillary wall should be thinner than the tubular basement membrane of a normal tubule. You have to find a normal tubule in order to make that assessment. And so here we have our capillary wall being about that thin. It's quite thin. And then we go to the tubular basement membrane of an adjacent healthy tubule, which these are probably our healthier tubules. And the TBM is much thicker than the glomerular basement membrane of this perfused glomerulus. So, and I don't see evidence of remodeling. So I was able to email Dr. Lobato as soon as I got the biopsy samples to say, hey, this is really chronic. A lot of the changes are irreversible. There is a hint that something went on way back when, because we at least had, not only do we have evidence of a single fetal glomerulus, but we also have regions of interstitial fibrosis and glomerulosclerosis. So whatever happened likely happened a long time ago. And then the other thing that we talk about when we're worried about the possibility of maldevelopment is whether or not the collagen deposition is associated with inflammation, or whether the collagen deposition is kind of devoid of inflammation. And again, we have not looked at the data yet to verify that this is a diagnostic feature. It is something that at the IVRPS we see in younger dogs that have maldevelopment, is that they'll have collagen and they won't have a lot of inflammation associated with that collagen. Whereas if they have inflammation and collagen in the same location, then we wonder that fibrosis is post-inflammatory fibrosis. This dog kind of has a mix where we have large regions where it's just collagen, like there's no inflammation in here. But then we go to the other portions of the core, a different area, and we have collagen admixed with inflammation. So we have kind of two different overlapping patterns of this guy might have some post-inflammatory scarring, or he also could have just had some abnormal amounts of collagen to begin with. All of this is going to say that in my interpretation of the histology, it could be a multifactorial disease process that we're looking at. The dog, it is possible that the dog might have had abnormal maturation. But all of this other stuff with all the degree of glomerulosclerosis, the degree of synechia, the degree of inflammation in some regions makes me think that even if there had been maldevelopment, we have a superimposed process on top of it. And so again, not every dog fits into a single category, and some dogs will have had abnormal changes to begin with, and then they have a second disease hit them. So, but I did email Dr. Lobato immediately and say, hey, there's chronicity here and there's irreversible changes here. I don't want the owners to like waste their money if they if they want to stop now and not pay for the EM, because I'm pretty sure whatever we see here is going to stay here and it's going to be really hard to treat. But they were very gracious and they wanted to go ahead and contribute and do everything they could to get as much information as they could from this case. So we proceeded with the IF. Unfortunately, there were no glomeruli available in the IF sample. I just make sure that was true. I'm not misspeaking that. Yeah, the sample did not have any glomeruli. We sectioned it through the entire thickness. And then we did the EM. And I think the best way to do the EM is maybe present it from the report. I might do that.
Rachel, before you present that, Peter has a question. He said, I have a question about evaluating parietal epithelial cells. When do you call hyperplasia, and is it a common finding in glomerular disease?
It's a good question. So the parietal epithelial cells that line Bowman's capsule, okay, quiz question. And we do have a hands up from Dr. Raquel as well. But I would like people to vote. Please raise your hand. I'm going to give you two options to answer this. So you have two options. This is a spontaneous pop quiz question. Should the parietal epithelial cells be either squamous or cuboidal in a dog? So anybody who thinks that the parietal epithelial cells should be squamous epithelial cells in normal ones, please raise your hand now. Okay, we've got a couple people might not be listening. I can understand that. Okay, we've got Dr. Sarkin voting. We've got Chris. Okay, good. Okay, cool. So we've got a couple of hands that say that they should be squamous. Okay, so everybody else put your hands down again. And now, should the parietal epithelial cells be cuboidal? Vote for that if you think that the parietal epithelial cells of a dog, a normal dog, should be cuboidal. Okay, we've got one vote. Okay, so we've got a few votes to a couple of votes, and so the normal dog parietal epithelial cells should be squamous. They should be a single layer of squamous cells lining Bowman's capsule. A male mouse has cuboidal epithelial cells that line Bowman's capsule. They have cuboidal parietal epithelial cells, but most other, even female mice and other species have a single layer of squamous epithelial cells. Now, when the glomerulus is damaged, they often become cuboidal and even sometimes columnar. And the thought or the theory is that if the parietal epithelial cells are lost, they can be repopulated by migration of the proximal tubular epithelial cells, so that the cells that might detach that are parietal epithelial cells, then they can kind of have an ingrowth of the proximal tubular cell back into Bowman's capsule. So oftentimes, if you see glomerular injury, you'll see thickened or hypertrophied parietal epithelial cells. They really shouldn't pile up on top of each other. You should only still have a single layer. And if I see it frequently in a biopsy with a lot of cuboidal or columnar parietal epithelial cells, we even call the lesion tubularization of Bowman's capsule. Again, it just probably shows that something was strong enough to come through and kind of selectively kill the parietal epithelial cells. What was that the end of your question, Dr. McGinn, or was there more? I'm not sure if you can speak. Sometimes you can speak and sometimes you can't.
Yeah, no, that's perfect. I was just wondering if we see it very often in glomerular disease, or I guess I was wondering how much weight you would give it, but it sounds like you answered that pretty well.
Yeah, I think it's always something I comment on, but you can see it in the absence of primary glomerular disease. Like if you had a toxin that killed off parietal epithelial cells and even, kind of damaged that tubular junction, and then you wait a few days, you'll see tubularization, and that's just kind of the healing process. So it's something I will comment on if I see it regularly, but it doesn't have a specific, it's not like a pathognomonic of any specific lesion or disease process. Okay, and then Raquel, did you also have a question?
Yes, when you talk about renal maldevelopment, Rachel, do you see that since the beginning, like the connective tissue there, that is like you talk about the connective tissue without the inflammatory component? So how, or this, evolves as, the months or the weeks go by? Like how much connective tissue, I would like to know if the connective tissue builds up on the lesion, as the animal grows. So
That's a good question. And so to be clear, the original papers that talk about renal dysplasia, which was the term that they have used for decades, says that you should have fetal glomeruli, you should have metanephric or primitive mesenchyme, excuse me, is the word that they use, and then metanephric tubules, which is kind of a collecting duct type lesion, and then possibly chondroid or osteoid in the kidney. We never see the chondroid or osteoid. We've never seen it. What I typically see, now, this is not a classic maldevelopment case. I do not think that this dog only has maldevelopment, this particular dog we're talking about. But I think that there could be a background of, hey, the dog just doesn't have its full complement of nephrons that it technically should. But usually in our more classic, like, we know this is maldevelopment because the clinical history fits a little bit better. The dog can't concentrate his urine. Usually they're not that proteinuric in maldevelopment. They will have kind of huge regions which don't have any tubules at all. And those huge regions will be just collagen. And so in our particular case we're looking at now, there was collagen separating tubules, but there wasn't huge regions that were devoid of tubules. I could still see the tubules, and I could see that some of them had undergone atrophy, that one that was over in the trichrome. So when we look at cases that we suspect it is still fetal glomeruli and immature glomeruli. And then it's regions that are devoid of tubules. And then the regions that lack tubules will just have a whole bunch of uninflamed collagen. So collagen that lacks inflammation. Okay. I think whatever happened with this dog, it very well could have had a component to begin with, and then we had superimposed disease. And the fact that it's so young made me concerned that something had happened a year ago, maybe even when the dog was born. And could it have been a neonatal infection? If they had, an ascending UTI as a puppy, and now what we're seeing is the remnants of that process, is very possible. Okay, is there any other questions?
Thank you.
Does that answer your question?
Yes, yes,
okay.
Thank you.
Okay, so now I'm going to share the EMs, and the only caveat with the EM is that the glomerulus that we had, we trimmed all the sample, and I think we only got one glomerulus, and it was pretty sure. Let me double check. Yeah, one glomerulus, and it was also one of the ones that was undergoing sclerosis. So it was an atrophic glomerulus. And I don't want the thumbnails. Go away. Hide sidebar. Okay, there you go. And so even though it was undergoing sclerosis, we can still make a few considerations and find a few pieces of information that are helpful. So here we have the GBM. It has a lot of cells inside of it. So we have kind of this evidence of cells that are growing into the GBM. So usually they're the mesangial cells that are doing this. It's quite thick and it's kind of wrinkled. So that is kind of a classic lesion that's going to be seen throughout in all the images. This particular cell here is an endothelial cell, and the capillary wall itself is very wrinkled. Again, that's what happens when glomeruli undergo ischemia. They, when they're poorly perfused, the capillary wall kind of just wrinkles and shrinks down on itself. And then you can kind of see these tiny little areas where you have cell membrane outlining a portion of a cell, usually they're mesangial cells, kind of in the wall of the glomerular basement membrane. Here is an endothelial cell that has lost its fenestra. And there's all kind of just fusing together. It was not an easy glomerulus for Dr. Hokamp and Dr. Nabity to image, but at least the conclusion can be that we have the GBM here. On this left-hand corner is our endothelial cell cytoplasm with our little fenestra in between the cytoplasm. fragments. And then out here we have podocyte, and you have fusion of podocyte foot processes. So the podocytes are damaged, which we were also able to pick up on the H&E, right? Or sorry, on the light microscopy. We saw it with the PAS having those protein droplets, and in that trichrome having that kind of vacuolated podocyte. It was kind of wrinkled, so some of this is artifact from the EM procedure, but again, we've got a good endothelial cell nucleus here. We have a thickened kind of capillary wall, and then we have effacement of podocyte foot process. All of this is mesangium. It's actually probably a little bit too much mesangium, so there's a little bit of mesangial expansion. Again, this glomerulus is undergoing atrophy, so we're not surprised by any of that. This is a nucleus that's inside the mesangial zone, so a lot of mesangial matrix hanging out in the mesangial zones. And so at least the utility of the EM in this chronic irreversible renal biopsy, the renal biopsy has chronic irreversible changes, is we were able to prove to Dr. Lobato that there really isn't an underlying immune complex component. None of the EM images showed any evidence of electron dense deposits in the capillary walls. So we could at least rule out that there is this possible superimposed lesion, or maybe even the main driving lesion, is not immune complex mediated. We did not have glomeruli on the IF, so we can't also use that as a piece of evidence. But this glomerulus doesn't have any electron dense deposits, and so we don't think that the pathogenesis involves immune complex deposition. So that gives her some information that she doesn't need to immunosuppress this patient. Literally, she just kind of has to optimize her standard therapy based on the fact that we can't find anything to suggest that there's immune complexes. The other thing it helps us with is that one disease that can happen in young dogs, especially young male dogs, and they're usually younger than this, they're usually like 6 months old, is abnormalities of the glomerular base membrane with mutations due to type 4 collagen. And so that's the Alport, canine Alport syndrome. And in those cases, we should see severe multilamination of the glomerular base membrane. And we didn't see that in this case. So we could at least also give her information that this dog isn't an Alport dog. Not that you can treat Alports, it really wouldn't have guided therapy, but it is an intact male. And so if it had Alport, or we had any evidence that there's like abnormalities in the glomerular base membrane, it would be inadvisable to breed this dog. So we could give her 2 pieces of information based on that electron microscopy report of, there's nothing else to treat. Immunosuppression is really not going to do anything for this dog. And then this dog doesn't seem to have one of the very few inherited glomerular defects that we know of. And so that at least gave some piece of information and maybe some peace of mind. Does anybody have any more questions about the EM? Okay. I'm going to see. Hold on one second. Dr. Nabedy and I gave a presentation of,
Rachel?
Yes, go ahead, George.
Before you leave this case, I want to ask you make a comment with a question buried in. First of all, with regard to the observation of areas of non-inflamed collagen absent tubules, I've always, and so the question is going to be, does this construct sort of fit with you, or should we be thinking of it some other way? Yeah, kidney tissue is 4 elements: glomeruli, tubules, vasculature, and interstitium. And I've always thought of those, if you will, collagenous areas as the result of collapse of the interstitium and consolidation of the extracellular matrix of the interstitial tissue after you subtract or fail to develop tubules and or glomeruli. And that's different than somehow a proliferation of a fibrotic process that generates more collagen. Which or both or neither of those is really what you think is happening?
I think the way you stated, I don't know if I would use the word collapse. I would just say that because you didn't grow tubules there, the only thing that was still there to grow, because the conversation or the type of renal maldevelopment that we see, and we probably is mostly in a dog renal maldevelopment, is the ureteric bud growing into the mesenchyme that's going to eventually make the kidney, and in sometimes failing to branch or branching at the wrong time or branching at the wrong direction. And so if you didn't grow a collecting duct into that region, you're not stimulating all of the stem cells there to become the rest of the kidney. And so because none of those stem cells are stimulated, everything just kind of stays in its interstitial state. And so I think that's the first scenario is how I think of it too. It's nothing grew there, so whatever's just stayed there.
Not necessarily collapse, but
yeah.
Consolidation or failure to expand. Like a bread dough that didn't rise,
Correct.
It's got no holes in it. It's just solid.
That's actually a really good analogy. Maybe we'll use that for so I do want to say, and actually I might just, instead of trying to launch the poll, I'll see what I can do, but that we do have a kind of an analysis that Dr. Editali is working on at AMC. So the question that we're trying to answer is, what are the ultrasonographic findings of dogs that are definitively maldevelopment based on biopsy, versus this kind of age-matched controls that were diagnosed with something different. And so so he is trying to obtain a lot of the ultrasounds of the dogs that come through our service, and getting the ones that we know that are truly maldevelopment based on having many fetal glomeruli, having many immature glomeruli, having huge regions that lack tubules, even maybe abnormally shaped kidneys, maybe even like failed deformed kidneys, those kinds of things. And so he's collecting those ultrasounds. And then once we have our cohort of those animals, then we will try to go through and find age match controls and hopefully breed match or at least size match controls for each of those dogs, to compare what the ultrasound shows. Because, and it's kind of a little bit of backstory about why we try not to use the word dysplasia anymore. There was a clinical concern from our nephrologists that ultrasonographers might overuse the term renal dysplasia when they're looking at the ultrasound of a young dog, and they might see any kind of thing like a scar, previous pyelonephritis, maybe an infarct, and just say it's dysplasia because it's a young dog and it has a depression. And so the nephrologist
diagnoses by ultrasonographers is, an overreach, if you will.
Yeah, exactly. So there was kind of a concept or a question from the clinicians when we were trying to establish the atlas, of if we could at least adopt a different term, then it won't be as confusing as the radiologist throwing the word dysplasia around a lot of times. Plus, the concept of, usually when you're talking about cancer, you go through a dysplastic phase and then you go to a neoplastic phase. And so like if you're thinking about squamous cell carcinoma, you usually have a dysplasia of the squamous epithelial cells on the skin, and then they eventually become neoplastic. So it also gets rid of that whole entire connotation as well. And so we chose the word maldevelopment, bad development, I guess, is just what we wanted to emphasize. And so this particular case, I don't know if I would even enroll it as a maldeveloped case, because I think something else happened to this dog. Even if there had been a component of some kind of arrest somewhere during some point of development, this dog had something else at a very young age, because this amount of glomerulosclerosis, this degree of proteinuria, and this degree of this kind of clinical presentation fits much more with a previous really bad insult in a kidney that we at least know is non-immune complex mediated, and we know it's not abnormal GBM. So it's almost more of a diagnosis of exclusion than actually being able to get a salient disease category for Dr. Lobato. So it is one of those types where we're almost just ruling out other things she could treat as opposed to giving her the actual true diagnosis.
Perfect.
Yeah.
One other thought, and it's come to me while watching this case go by, and I don't know that I could point to this case and say it's clearly this kind of thing, but we talk about failure of development of tubules and branch chain, tubular branching and stuff. But what about development of the vasculature? You know, we maybe there's a potential for something to go awry with the coincident development and expression of normal vasculature that would then choke off everything else in a way
totally
that might end up looking like this to a degree.
I think that's a really good point, and I think that even in like I said, like the classic lesions we think of maldevelopment, we still often see, and it's a matter of section, right? Because you're not always going to get a great arterial or a great artery in your biopsy section, but we do see a lot of tortuous vessels and a lot of vessels that are thicker walls than normal, and this particular dog had it as well. This dog had some degree of hypertension, so that also could have contributed to the thick vessels. But yeah, we still don't really have a good cutoff for what our vasculature should look like and how thick our vasculature should be. I think arteriosclerosis is completely overlooked by a lot of pathologists, especially when they're looking at kidney. So I think that's a good question about like, what if we just didn't have enough VEGF? Like what happened in the kidney if there's, abnormalities or there's too much VEGF and we had too many vascular profiles. So all of those things are groups or conditions that would possibly contribute to a kidney that just didn't have the normal number of nephrons, the normal number of vessels, the normal number of glomeruli. And as we try to emphasize that in a small dog, which this dog is small, so he's supposed to have a lot of renal reserve, a lot of extra nephrons, more than he needs. And so, whereas if you had a dog that was a Great Dane and didn't have as many nephrons as possible, then it's supposed to be much more prominent, affecting them as opposed to affecting the smaller dogs. So, again, I don't really think we're going to have an answer for this case. It does sound like they're going to do quality of life and make the dog feel better, especially if he's if the telmisartan's making him feel kind of crappy. But the lesions in the kidney are severe, they're irreversible, they're chronic. And so I think that the decision to say, we're just going to hopefully he feels better and he's going to eat well and enjoy and have his level of energy. Because I don't see this kidney being living to become a 10-year-old kidney, just based on how much scarring we already have. Does anybody have any other questions? Nephrologists, do you guys have any comments about the kind of the chronic, when we give you a diagnosis of chronicity in a young animal? Okay, doesn't seem like there's that much. Oh,
Rachel, I just want to say I was really surprised when the first and maybe the only USG that Mary provided was 1039. That was well concentrated and that confused me.
Yeah, and like I said, I think that so what Mary Nabby is referring to is that a lot of our dogs with true maldevelopment, with really great evidence of maldevelopment, they can't concentrate their urine. And so we have usually USGs in like 1010, 1012. And sometimes that's the only clinical sign that we have, is that they have isocynuria, even though when they're going in maybe for their check prior to spay or neuter. And so that's the first flag that something's different. And then they follow up, and then we have a non-azotemic, usually non-proteinuric dog. And so this dog isn't fitting that clinically. It's not fitting that. It's proteinuric. It's able to concentrate. It has a degree of azotemia. Again, so that even no matter what happened in this dog, that the original situation, original scenario that exists, something else added onto it. And whether it's a viral infection, a pyelonephritis when it was young, abnormal podocytes. Maybe this is all a podocytopathy and we're just looking at really, really, really bad FSGS. And now we're almost to the everything's GS diagnosis. So something's very specific about this dog that isn't just the typical things we would see for a maldevelopment case. Any other questions? Okay, well, I know I previewed that we were going to do a poll and I didn't actually launch the poll because we started talking about other things. But I do think that next time we will hopefully get a case that will have some ability. Maybe I'll just work it into the actual presentation for poll questions so that people can, instead of being put on the spot, like I put some people on the spot today, everybody could just reply via an anonymous way via their phone or via their computer, just so that we can get more engagement. So that will be in November. Let me double check to make sure it doesn't overlap with Thanksgiving. I don't think it does. So November's would be the 19th. And
FYI, that'll be the last day of ACVP. So so either a lot of people will still be there or possibly traveling back, just as an FYI.
Well, the clinicians won't be there.
That is accurate.
Okay. Well, I'm still gonna have it. You can miss it.
No, I'm just telling you that your pathologists and your residents might be missing.
Well, I'll know who's committed when I see who calls in from the plane.
Well, there you go.
Okay, but we'll probably still have it. Hopefully we can get a case that's requested pretty soon. And then we can, I know Shropshire still has a case she really wants to talk about, but every single time we have rounds, she's on clinics. And so if it will be that rounds or maybe it'll be in December, but she does want to discuss the case. So, but we will have a round set up for November 19th. And I will send out a case request soon. And if there's any questions or any other comments, or you want to add more people to the list, please feel free to send me an email and I will add them to the distribution list. It does look like Dr. Lobato probably left us to go take her nap. So hopefully she's able to recuperate and dialyze her next remaining patient. Any other questions? Okay, I'm gonna check the chat and then you guys can head off and we'll see you next month.
Thank you. Thank you.
Hogan, are you still there?
I am.
Thank you.
Oh, I see what I saw. I was wondering what you had put to whatchamacallit. Oh goodness. Okay, so everybody's doing that. Okay, so I think we will, when Haley Dodson has any questions about dissection and stuff, I'm going to be walking to the med school soon, so you can message me on Teams and stuff, but if you really need me, you might just call me or something like that.
Yeah,
is she dissecting them this afternoon? They're JD, they're your kidneys. If he's available. Not sure if he might have wandered away from his computer, but
yes, she and I are meeting up here shortly, and she brought some tools over so that
you need like a micro scissors.
Yeah, that's the thing. Scissors. We didn't have a good micro scissors that we were comfortable with using. But I was going to show her your messages of like what to do that you had sent with us on how to section and see if that makes sense to her. Show her she's seen the images, but then show her the tissues and let her see if she can has an idea of how to do it. And then if not, we'll definitely